Good afternoon, everyone. My name is Amy Bergin, Alumni Relations Officer at Trinity College Dublin, and I'd like to welcome you to today's Inspiring Ideas at Trinity webinar on the COVID-19 crisis, frontline challenges, strategies, and vaccination hopes. I'm absolutely delighted to be joined by our speakers today, Professor Michael Gill, Dr. Clíona Ní Cheallaigh, and Professor Colm Bergin, for what I'm sure will be an insightful and fascinating discussion. We have had huge interest in our webinar today with over 500 alumni registered from all over the world. We encourage attendees to ask questions throughout using the Q&A button at the bottom of the screen. Some of you have already submitted your question in advance, which is great. Our speakers will do their very best to answer your questions. The talk today will last about 30 minutes and we leave a good 20 minutes for the Q&A. We hope to be wrapped up by 2 p.m. Irish time. Now I'd just like to introduce Professor Michael Gill, who will lead the discussion today and introduce our other speakers. Michael is a professor of psychiatry and head of discipline at Trinity College Dublin and consultant psychiatrist at St. James's Hospital. He leads the Neuropsychiatric Genetics Research Group. In 2012, he was also appointed as director and principal investigator of the Dublin Centre for Clinical Research. That includes a network of clinical research facilities, including the Wellcome Trust Clinical Research Facility at St. James's Hospital, which opened in 2013. So now I'll hand over to you, Michael.
Thank you so much, Amy, and you're all very welcome this afternoon to this webinar. I'm the head of the School of Medicine at Trinity College and certainly not an infectious disease expert. Here simply, my role is to introduce the real experts, Professor Colm Bergin and Professor Clíona Ní Cheallaigh. Just before I do that, I'd like to, by way of background, mention that in our school, many of our staff, such as Colm and Clíona, have dual appointments in hospitals and healthcare services and are working extremely hard in these very difficult circumstances to deliver teaching, conduct research, and provide clinical services across all specialties. We're also pleased to have so many healthcare professionals, hospital consultants, general practitioners, physiotherapists, occupational therapists, and many, many more professionals associated with the school with honorary appointments with Trinity College and who, with no dedicated time or payment, support clinical placements for our students and provide clinical teaching. We're very, very proud of their work during this pandemic and grateful to them for keeping up with their teaching activities despite the difficulties caused by COVID-19 so that our students can qualify and join them as junior colleagues. Now to introduce Professor Colm Bergin, a senior consultant in infectious diseases in St. James's Hospital, professor in infectious diseases at Trinity, co-national lead for infectious diseases clinical care programs in the HSE, a member of the expert advisory group for COVID-19, and a member of the National Public Health Emergency Team, an excellent clinical researcher, and a lead or collaborator on multiple COVID-related studies. And moreover, he would be the one doctor I would want to have as my doctor. He's a real hero to me. Professor Clíona Ní Cheallaigh, consultant in infectious diseases and general medicine in St. James's and clinical lead of Inclusion Health Services, and an associate professor in clinical medicine in Trinity. If we had the opportunity on another occasion, we could run a whole seminar on Clíona's research and clinical work with some of the most disadvantaged and marginalized people in our society, showing us the severity of illness in these people and working on better methods of providing healthcare. But she is here representing her skills and knowledge as an infectious diseases expert. So I might start with you, Colm, if you'd like to maybe tell me a little bit about what your days are like these days and the responsibility that you carry.
Thanks, Michael, and good afternoon, everybody. And I'd like to also acknowledge Amy and Alex for organising today's webinar. I suppose my day, I'm very fortunate in two ways. I am surrounded by a great team, one of whom is joining us today, but also I have diversity in what I do. So my clinical work has continued. I'm presently on the floor for the non-COVID related infection services. So we run a program looking after immunosuppressed and general infection related complications in the population and a HIV positive inpatient ward that I'm presently on the floor for. I have continued my research interests, as you've identified, Michael, some of those at this moment in time are COVID related, but I have a number of PhD students that I'm still trying to ensure that I look after as they come towards the closure of their degrees. I have an active role in the Department of Clinical Medicine, so we have been adapting, obviously, as you've mentioned, our teaching programs in the last year to ensure that we look after the next generation, particularly the final meds who will be joining us on the floor in the coming months. And then I suppose administratively, I've taken on some ID related roles, both at a hospital level in preparing and adapting to the changing waves of disease of the last 11 months, and at a national level within the HSE as national lead, and at NEFIT, which continues to contribute towards the public health information to government. So I think I have a diverse day, probably not enough hours in the day. But that said, I try to blend all components, supported by obviously a significant support from the team.
And sometimes with Colm, you never know whether he's up late writing an email or up early writing an email, because they come in the middle of the night. Moving on to yourself, Clíona, you're really in the front line in St. James's. I wonder if you could give us a little picture of what it's like there in St. James's for you and for the other healthcare professionals.
So, of course, thanks, Michael, and thanks so much for inviting me to speak. That's lovely. So I'm a consultant on a COVID ward at the moment. So I switched from my normal clinical activity, which is Inclusion Health, the service that we set up to look after people who are socially excluded. Due to the pandemic, I've been pulled into clinical care for on a COVID ward. So I have between 12 and 15 inpatients under my care at the moment. I did a ward round this morning to see them all, and I work with a team of junior doctors and nurses and physios to look after them. It's really tough. I think there's a lot of sadness. So for example, one of my patients today, her dad is dying in ICU and she's not able to see him because she has COVID. Another lady, her husband, she was in A&E. She came in with COVID last week and she was rung while she was in A&E to be told that her husband had passed away from COVID. So there's a lot of grief on the ward, and I think I've many years under my belt of working on the front line and I suppose coming to terms with people dying and grief and sadness. But I do feel for the younger staff, it's a very heavy burden for them to carry. They're fourth year nursing students on the ward and stuff. So yeah, that's the reality at the moment.
Thank you, Clíona. I mean, I can only imagine what it's like and the sort of controlled chaos that's going on, and the human stories behind all of these masks and PPE outfits and things. It's really quite amazing what you're doing. Maybe I could just move on and ask, we've lived with this now for coming on to a year. What do you think we've learned? How has our understanding of COVID-19 changed? And the treatment strategies, have they developed over time?
So I think the key treatment strategy that has changed from the first wave is dexamethasone. So we had kind of intuited in the first wave that it might work, so we used it a little bit, but not in everybody because there wasn't evidence to back it up. And now we routinely use it on anybody who requires oxygen. And I think in the second wave, which was in the autumn, it definitely seemed to be reducing mortality, less so in this wave. And I think that's probably because we're dealing with a lot of cases of a more virulent, the UK variant, where it's more severe. So they estimate, dexamethasone probably reduced mortality around 30%, and this new variant is around 30% more fatal. So we've kind of ended up back where we were. I think the understanding of how to protect ourselves has really changed, and a consciousness of it being very much transmitted by inhalation. So wearing masks, not sharing break rooms, not having lunch together, not having coffee together. I think that has really changed and has made a big difference.
Yeah, just moving back to Colm for a moment. Do you think overall has Ireland managed the pandemic well, or what lessons have we learned?
I think overall the population had handled the pandemic well. I think for the most part people have engaged with what they've been asked to do. I think for the most part we have adapted as circumstances have changed. I think our challenges, however, remain significant. I think we continue to have the same infrastructure at a healthcare level. That hasn't changed since last March. We still have 6 to 8 people sharing a ward with a single bathroom. We still have an infrastructure with limited side rooms available for a highly transmissible infection, and increasingly transmissible, as Clíona has advised, in the absence of immunity for the majority of the population. And similar to Clíona's story, I had an unfortunate case this morning of a woman who's 60 days in hospital waiting to have her aortic and mitral valve replaced for staph aureus endocarditis, who's now just been informed that she's COVID positive. And that has occurred in-house. So I think we have done well at a population level, Michael. I think people have adhered to cycles of lockdown that can't continue. I think there has been consequence both economically, but also with regards to mental health, as you'd be well aware. Our educational system, our more vulnerable groups in society, children included. But I think when you look internationally, I think back to your question, have we done well? I think only time will answer that, Michael. But at this particular moment in time, I think we are looking to address, we're looking to communicate, we're looking to learn. I think the pandemic has probably exposed certain infrastructural deficits, not just within the healthcare system, but within preparedness, within public health, within occupational health, within research, within networked research, within communications, and within society. I suppose we've lived our lives in a different way in the last 20 years, or compared to when I think about my parents' generation, our life in the last years has been totally different. So I think what pandemic has done is probably exposed certain societal issues.
Thank you.
I want to talk to.
I mean, just in relation to, you mentioned about, getting COVID in the hospital, and that clearly has happened, but it also happened to healthcare professionals. And you've been lead author in the PRECISE study, which compared, looked at the rates in healthcare workers, both here in Dublin and in Galway. And you found that it's increased, but related to the population rate in the background.
So PRECISE has been interesting. It has been supported by NEFID and by the Department of Health and the HSE, but it was a study between St. James's in Dublin and Galway Hospital looking at the rate of antibodies, or the prevalence of antibodies amongst healthcare workers. And we advocated for this to be done to try and get a better understanding of what was actually happening for healthcare workers. If we look back to wave one, it was clear that healthcare workers were one of the most disproportionately affected groups. When you look at numbers, obviously there were others that were more disproportionately affected by both morbidity and mortality. But it was unclear what contributors led to that significant prevalence. So was it background community rate, which, as you've referenced, we identified within the study, but also influenced by social factors. More likely to have a positive antibody if you shared your home with somebody else, and much more likely to have a positive antibody if that household contact was also a healthcare worker. Obviously, people commuted to work, we socialized in work, we had certain infection prevention and control practices at work, and were there different components that were demographic related, discipline related, as opposed to healthcare associated in the context of community prevalence. So we've been very fortunate. We've tested over 74% of the population in those two hospitals. More than 6,000 people consented to testing. It's been remarkable, Michael. I think that has been the other thing. Apart from society joining, healthcare workers themselves want to contribute. They're looking to participate, to inform, to understand, and to help, I suppose, others in trying to understand what has been the risk of acquisition of infection. We completed that in October with a plan to run it again in March across both sites. And what will be interesting this time around, apart from looking at prevalence of infection acquisition over time, antibody response over time, is that now we'll begin to see the impact of vaccination over time, given that both hospitals have rolled out vaccination. Whilst everybody hasn't yet been vaccinated, the majority of healthcare workers on both sites have. And this goes back, I think, to our role as advocates, our role as researchers, our role as asking questions, seeing something in Frontline. So we saw this last March, April and May. I was on the wards for those 3 months, and it was clear that we were seeing this. We run the testing program and the testing pod in the hospital, we were clearly seeing a disproportionate impact, and then asking, well, what exactly is happening? Looking to create the research question, looking to advocate for the funding, carrying out the research, and then hopefully informing.
Thanks, Colm. I'm conscious of some questions coming in, and I might just take one at this point before we move on, and that's a question about why are we not testing everyone for the presence of the virus and also antibodies to ascertain the true figures of who's already immune? You know, an element of perhaps some wastage in the testing. Why not go upstream to the source and test all individuals?
So I might start, Clíona may want to come in on that. So there are seroprevalence studies being undertaken. So the SCOPY project, which was a seroprevalence study in the general population, invited almost 6,000 people residing in Sligo and in Dublin to participate in a antibody testing program. That was done to inform the very question that our colleague is asking. The difficulty obviously is the logistics, capacity for testing, and the ability then to look at how you would use that capacity to best return when there have been differing demands on the system over time. So the thought of running something now at a time when we have so much infection, which is prevalent and driving our healthcare utilization, it will be difficult to offset or transfer that capacity into another research question. But I would concur with the question. We need to test more. There has been a call for testing since last March, and a call for a national strategy to look at an approach to testing, acknowledging the difficulties about the sensitivity of different tests, the specificity of certain tests, the ability to interpret those test results pending community prevalence. But this is not to replace what we're already doing. This is to add to it. And certainly in the context of healthcare sites, the rollout of serial testing in the residential care facilities in certain occupational settings, such as factories, needs to extend to other healthcare settings where high rates of infection are occurring. So we're hoping to roll that out in the coming weeks, Michael. Late, but we're hoping to do it.
Thanks, Colm. We're also getting quite a few questions on vaccination, as you can imagine, and I might want to move on to that now and maybe ask Clíona a little bit about it. I know from various friends and that they talk to me about the mRNA vaccine. I'm not sure whether they know what mRNA stands for, but it's out there. If you could tell us a little bit about the COVID vaccines, because I know it's a fascinating story of science over a very short period of time.
It's really remarkable. And yeah, I have a background in immunology, so this just blows my mind. It's so cool. So there had been a lot of work done over the last 10 years and really kind of blue sky experiments, a lot of them looking at different ways to vaccinate. So some things that we can vaccinate with are, your body will naturally make an immune response to that thing. You can give a weakened strain of a virus and your body will naturally make a response that will protect you. But other vaccines need different types of technology. And the mRNA vaccines have been developed really for cancers. Because there is probably within, I would say, the next 5 to 10 years, there will be anti-cancer vaccines. So where you can teach your body to recognize the cancer cells and for your own immune cells to destroy the cancer, which will be fantastic. So they had this technology ready to go, and it's amazing. So the mRNA is like a recipe for a protein. So normally we would put a protein into your body to get it to mount an immune response. But in the mRNA vaccine, you're just giving your body the recipe so that your body itself, your own cells make that viral protein and display it on the surface of the cells and create an immune response. So it's just amazing. And even the technology and all the steps involved in how do you get that mRNA into somebody, it's amazing. And I think, it's been remarkable how quickly we have so many different vaccines. And I think it's testimony to actually many, many years of really solid research in many different vaccine aspects, that they were ready to go once we had the disease and the genetic material of the disease identified. But yeah, blew my mind when I got the vaccine, and you can feel it, and then you're like, oh my gosh, it's like science fiction.
It is extraordinary, and I suppose we could spend an awful lot of time talking about that, but there's a couple of questions in relation to the vaccine. So one question here is that we know the vaccine is 95% effective in stopping people getting unwell from COVID. When are we likely to know if the vaccine stops vaccinated people from spreading it?
So that's a difficult question to answer. I don't have an exact figure in mind for that. I know there's been lots of debate as to whether or not the vaccines are likely to prevent transmission. And one would hypothesize that they probably at least will reduce it. It definitely seems that people who are vaccinated, if they do get infected, have much less virus in their nose. And we know that, you know, a lot of the spreading depends on how spreadable you are, how much of a spread you are depends on the burden of vaccine. And we know that a lot of other vaccines do prevent transmission. So, you know, measles, mumps, rubella, we vaccinate kids and you know, that prevents transmission onwards, but we don't know for sure. And I suppose it'll take some time. So we'll need to, first of all, have, you know, that significant numbers of people in the general population have been vaccinated with both doses. There was worrying news coming out of Israel showing very high rates of infection, even though 25% of their population had the first dose, but they hadn't really got to the point where you'd be able to test the vaccine efficacy. I suppose in the next 6 to 12 months, would you think, Colm, we should start getting a feel for how that's going to work?
And I think,
how long does it last is the next question. How long does the immunity last? So there are many questions that remain to be answered, but there's a lot of money and a lot of man and woman power going into research on this. So I think we will get answers as quickly as is feasible.
I would agree. I think there are two just issues, Michael, to add. One is obviously how long will it last? And so that's going to take some time as we're measuring. And then secondly, back to your previous question about testing, we need to test more so that we're following people through who may have like few symptoms or totally be asymptomatic with infection to determine whether or not vaccination has influenced their risk of reinfection. So I think vaccine efficacy surveillance will also inform transmissibility risk.
I suppose we can't say for the moment because we don't want people's behaviours to change when they have been vaccinated. So I think we're all being very cautious on how hopeful we are that it will in fact prevent transmission, because we can't afford to get that wrong and for people who've been vaccinated to transmit.
Yeah, I mean, it also relates, we might come back to this point, but it relates to how we see the pandemic develop over the next year and into the future, and what will happen if I came back in 3 years' time. What would the situation be like? But there's a couple of other questions here, if I might, and this is I think one which we spoke about a little. So research is obviously essential over a wide range of different things. How has COVID impacted research and innovation? Has it paralyzed non-COVID related research?
So, I mean, just speaking from personal experience, I've had to put several other research projects on hold due to COVID. So I think it has, for a lot of other health related research, has had to be paused.
But also there is a view that the science that has come out has been very prominent. People are very engaged with it, and there has been some increases in funding to make COVID research happen, but also to keep up with non-COVID related research. And maybe one of the things that will emerge from this is a better understanding of an engagement with science. Do you think that's a?
I mean, it's very clear the benefit of science, I hope, to people at large. I mean, having a vaccine within a year of a new virus is remarkable. And even how rapidly, you know, we had tests for it. I think it really it's testimony to the power of science. And I can't not mention my interest in social determinants of health. But I think the COVID pandemic has really highlighted the importance of considering those and having more evidence to address those. So I'm hopeful it'll turn out to be good. Sorry, Colm, I interrupted you.
No, I was going to agree, but just to add perhaps that I think two things have been highlighted. The first is that research informs. I think there probably was a perception within the general system that research was something that was an add-on or ran in parallel to, whereas I think the last 10 months has really brought networks, collaborations, structures together at a level to want to work towards something that we're all interested in learning about. I think that can only be a good thing, Michael. I think the second thing is that we have learned that we need to analyze data in real time and understand it to inform as we adapt, because otherwise we're going around in a circle as we've entered our third lockdown if we're not looking back and learning and not addressing things that we're seeing now to inform questions. And I suppose back to the example of the precise study, you see something, you have a question, you look to answer it, and that's all through research. So I think both COVID and non-COVID related research will benefit as a consequence of the last 10 months. The glass is half full.
Absolutely. No, thank you. And going back to one of the things you mentioned earlier on about the use of steroids in the illness and the value of that for such a economical treatment and easily available. There's a question that says there is an increasing evidence of a role of stress and trauma in causing inflammation peripherally and centrally, seems to raise immune markers. Is this related to the cytokine storm in COVID? And what measures in clinical practice are being developed to help reprocess this traumatic stress?
I did not plant this question, but whoever asked it, thank you. So absolutely, because if you look, anybody who has had to listen to me witter on knows I'm obsessed with this, but we don't understand how trauma, how those psychosocial factors affect people's health, despite multiple clues. And I think it's really clear in COVID that people who are poorer and who experience more psychosocial stress get much sicker by what is an immune-mediated disease. You get sick from when your immune system kicks in. You don't get sick when virus start to get sick in the second week when your immune system kicks in. And data that we need to get ready to publish from James shows that people who are homeless, despite being relatively young, that was the biggest, strongest risk factor for developing severe COVID and needing ICU or indeed dying. So I think it really gives us a push to try and understand those massive effects that all those psychological experiences, particularly in early life, have on setting the thermostat for how people's systems respond. Huge overlap actually, Michael, with psychiatry, where we're very high levels of mortality in people with chronic severe mental illness, and also very high risks of acquisition. So it's, that double whammy. They're likely to get it, and when they do get it, they're likely to get very sick. And again, that's scientifically unexplained. So fascinating research topic, and hopefully then will lead to a better understanding of how we're social but creatures.
Well, as you know, many of the those severely affected with the psychiatric illness also have physical symptoms and physical complaints.
Absolutely, because it's, they're not too
separate. Are connected. The two
Yeah.
are connected.
Absolutely.
There's a couple of questions, and they're sort of a similar theme, and that's around the safety of vaccines. In a general sense, and there's a few specific questions about pregnancy and things like that might be a little bit more difficult to answer. But have you any comments on the general safety that you've seen in relation to these vaccines? And now we're already rolled out quite a bit of vaccination in this country.
I mean, I see a lot of people, and I'm sure Colm has seen the same, who have, signs that their immune system is activated, particularly after the second dose. But that's a good thing, like I was very happy to get myalgia after my second dose because it tells me that mRNA is doing its job. So I think it's important to be clear that, some of those side effects are not necessarily something to worry about. There are worrying reports from Norway that Colm may know more detail about in very, very frail people who are probably approaching the end of their life anyway, that they seem to have an increased rate of death post-COVID vaccine, but that'll need more study before we can say for sure. But I think overall I'd be fairly happy with the safety profile.
Yeah, so I would agree. I just back to the Norway issue, that is in a defined group of people that are undergoing further evaluation and may have multiple confounders to the unfortunate outcome in the context of vaccination that hasn't been seen in either the studies or in surveillance settings anywhere else. I think the published data is reassuring. I think what Clíona is referring to is what is described: local reactions, some systemic events. There are some isolated individual medical episodes that are always unclear as to whether or not they're directly vaccine related or whether or not they're single events. I think the reassurance comes as we gain our own experience with rollout, as we gain our own experience with reported adverse events through surveillance, and as we link that in obviously with international experience. But to date, there hasn't been a concern. And I think it is overridden by the positive benefit of vaccination. I think it is incumbent upon all of us to ensure that we are advocating for the role that vaccination is going to partially play as we navigate through a pandemic in the coming 1 to 2 to 3 years.
I have a question here from what I think is a classmate of mine, so it has to get answered. So as residents of care homes get vaccinated, what will be the determinants of when to relax and remove restrictions on this vulnerable population? Who wants to take that one?
I'm happy to start because I think that the restrictions on residents of care homes are particularly harmful. And I think that this is really a very, very important question. Restricting visits of people in care homes has very severe impact on their and their families' well-being. So I think it's important to consider. I don't know if there's a time frame. Colm might know, do you?
So I think that's a really good question. So clearly, to acknowledge the person that was in class with you, Michael, I think we need to have a plan as to what we are going to do with regards to vaccinated population. So as you vaccinate more people, you have to begin to challenge what are you going to do. If you feel that vaccination is simply to address disease progression, then it is not going to alter our infection prevention and control practices. If you have no data on transmission, no data with regards to reinfection risk, then you can't, unfortunately, remove your infection prevention and control practices, your social distancing, your hand hygiene, your respiratory etiquette. And certainly not in populations who you may have a question as to whether or not they are vaccine responsive. So in residential care facilities, we may be vaccinating people over the age of 80, but a lot of people over a certain age may not necessarily have durable or mountable immunological response to vaccine. So I think it's a very challenging question, not just with regards to residential care facilities, but at a societal level or at a healthcare level. In the short term, we're not changing anything within the healthcare system. We still have to do what we have to do. If anything, we're escalating IPC practices in the context of new variants. But a time will have to come when we challenge the benefit of vaccination at a societal level to determine when do you get that equipoise between the need to maintain your IPC practice, you escalate your vaccination, you measure your durable immunological response and your reduction in disease transmission or disease acquisition, and then begin to relax your IPC practice. I think at least we're probably 6 months away. And I think that's very difficult for people, as Clíona has been describing, who are negatively impacted upon by the measures we ask them to live with.
Yes, I think the notion that vaccination is somehow going to very quickly open us all up is a difficult one. You know, it clearly is essential and a huge success and huge hope for the future, but it's not, I don't think, going to have such an immediate effect.
I think as well, Michael, it's to do with the consequences of making the wrong decision in opening up. You know, it's that risk benefit and the severity of the risk. We've seen how quickly this explodes out of control. So if you call it wrong, that's a difficult one to pull back.
We saw what happened over the Christmas period and into the new year, and that was extraordinary. I think it took everybody by surprise, even those who had predicted a third wave and hadn't really predicted quite such a severe third wave, and that's extraordinary. I mean, you know, one question I guess is it relates to a question that's on the sheet here, and that is the sort of zero COVID strategy, and whether that's something we should have been doing in an all Ireland situation, given that we're an island like, you know, New Zealand.
So I might just come in on that with just an anecdote, which is after wave one, I took 4 weeks off, the longest I've had off on a stretch, apart from maternity leave since starting working. And I remember I was midway through and there were reports of people flying in from the US, and, you know, there were Maria supposed to be quarantined for 14 days, but they were only here for a week and they were out in Grafton Street. And I remember the bottom of my stomach sinking at that. So I think that definitely there is something that we need to do around regulating travel when we're in a situation of low cases.
Do you think we should be pursuing this? I know it's in the media, it's often talked about.
Absolutely. I mean, absolutely. And I think, unfortunately, we can't trust, because it's the consequences of each small slip, or somebody saying, oh, I feel fine, I'll just pop out to the shop and get a bag of popcorn or whatever. I think we need to really look at how we do that on a you know, very supervised, managed way, rather than trusting people to do it, because it's very hard. I think over Christmas, you know, asking people who'd come over from London to stay in their room for 2 weeks, like with an Irish mammy on the other side of the door, ain't gonna happen.
So I don't normally disagree with Clíona, but I'm afraid I'm going to come in on this and say that a lot of this is about language. We all want the same thing. And there's this pitch of zero COVID versus non-zero COVID. Everybody wants the same thing. The definition of zero COVID, I think, is what probably gets people a little uncertain. So zero, as opposed to limited or small number or manageable or traceable or contactable. A two-island approach as an island, Michael, absolutely, we should be able to identify that. And that, I suppose, goes back to societal and political pressures that have perhaps influenced some of the decisions there. The travel is obviously, as Clíona described, something that has been on the table for a very long time. And if there was one thing that if you had your time again and were to look back to March 1st, 2020, that you would want to have explored, was to have pushed that question beyond the public health guidance to the political guidance and to the government decision. So we all want the same thing, but I'm just not sure I can advocate that I am a proponent of zero COVID. They have not attained it even in those countries that we hold up as the poster children. So I think probably it would be helpful to move away, to be honest. I'm not part of that group, but
I think we need a new
the
term.
language and say, what are the things we want to do that are going to allow healthcare return, non-COVID healthcare return, improvement in the psychological and mental health consequences, return of education, and hopefully the opening of the economy to allow us to return to what will be a new life in the context of pandemic. But I would just maybe question the thought that we can attain zero COVID.
We're actually in agreement on this as well.
I think Clíona was talking about travel as well, and the travel restrictions, and that's only part of the whole picture, I would have thought.
It requires a massive investment in our testing and tracing capacity. So what, public health tracing is still on paper forms, Michael. There's still no national IT. It's incredibly underfunded and understaffed. And what they do in countries where it works well is they take X person who has COVID and they go back 2-3 weeks to figure out where they got it and isolate. All we're doing here is really damage limitation. So you're just going back 24 hours, 48 hours to see if you can figure out who they may have infected. So we really would need a massive investment. And I think Colm and I have discussed this before, and our ID colleagues will all be in agreement. And that'll stand to us we can use it for other things afterwards. It won't be a waste of money.
Another question just on first of all, congratulations on the webinar, and it's very significant work that you're both doing. But then says, and I think Colm, you might be able to answer this, if you could ask the Minister for Health for 3 changes. And it's specific, the question is in relation to ICU and the hospitals and the isolation of the COVID patients there. And I know ICU has spilled out over onto the general wards, etc. What would be the things that you would ask our Minister?
So I think the first thing is infrastructure. I think that we had an opportunity perhaps in the summer, or an opportunity in general, to push better isolation facilities within the healthcare system. They don't all have to be brand new shining buildings, but they could be pod-based, or they could be rapid builds that would allow us to have. Now I acknowledge that it has to be met with machinery and ICU nurses and multidisciplinary members of a team that look after critically ill patients. But the first will be infrastructure for isolation with the appropriate resource to look after the patients depending on their care needs. As you've mentioned, there are almost twice as many people receiving non-invasive ventilatory support on wards around the country that are not in critical care. And I think that allied to the investment in critical care is to the investment in ward-based high dependency units that may not have the same resource requirement as intensive care unit beds. That's my first request. My second request is to roll out testing. We need to test healthcare workers more. We need to test them frequently. We need to engage them. Most healthcare workers will do it, as evidence from the PRECISE study. Most people are looking for it. And I acknowledge the logistics and the difficulties with the assays and the tests, and I'm not undermining that, but it is not that you're replacing one with the other, you're adding to it. So my second will be to support testing to keep hospitals safe, because this is going to turn out to be a healthcare associated infection in the near future. That people will come into hospital with condition A, like the lady I described earlier on, and 2 weeks into their hospital stay will acquire a disease that was unknowingly transmitted because of an asymptomatic case, either from a healthcare worker or from another patient. So testing will be my second request to the Minister. And then I think my third request would probably be to invest in research to inform, not just individual projects and individual research grants and individual networks, but actually analyzing those findings and that data to transform public policy, and then to communicate that obviously to those that are funding it, which is the community.
I mean, related to that, and you touched on it there, is the issue of care pathways that have been altered during the pandemic. You know, are we managing that well?
I think, Michael, from my psychiatry colleagues, an incredibly under-resourced sector of healthcare anyway, for many reasons. I think that, you know, years of maybe failing to invest in big structural resources that we need to deliver good care are unfortunately coming home to roost. As Colm has said, you know, we haven't invested in infrastructure, we haven't invested in IT, and yeah. More funding for psychiatry and mental health services.
Yes.
Very, very, very important.
Very, very welcome. As you know, when I started out in psychiatry, I think the health service spent about 12% of its budget on psychiatry. I think it's down to about 5% or 6% now.
I think just to bring some good, sorry not to interrupt, but just to bring some good ray to what has been a very difficult 10 months, has been that we have adapted, as have patient groups, to newer ways in which we do things. We have had to reflect on the way in which we run chronic disease care clinics. We have had to look at the way in which we historically booked people into our patients at a time that suited us for them to come and see us, as opposed to a time when perhaps they needed to be there because of their disease state. So I think IT infrastructure, virtual clinics, review of the healthcare system and process will become much more patient-centered where it should have been. So I'm not underestimating the significant challenges of COVID care and COVID pathways and infection control and isolation facilities, but there are some things that will come out of this that will actually enhance the experience for some patients who presently probably don't have a very patient-centered engagement with healthcare.
A number of sacred cows have been dealt with.
And I think it's amazing as well to see how quickly people can adapt. It's a little bit similar to the smoking ban, where, you know, for years we knew it was bad, and then suddenly the smoking ban came in and everybody stopped smoking. It's a bit similar. I don't think we could have predicted in January how quickly everybody would change how they do things. Huge flexibility and creativity.
And again, timing. I mean, if this had happened 5 or 6 years ago, I don't think the technologies that we're enjoying here on this webinar, for example, may not have been in existence, or certainly wouldn't have worked as well.
Can I ask the Minister for one thing as well, Michael?
Of course you can. Yes, absolutely.
So I really want the Minister to realise that health is also about social determinants, you know, and that he works together, or whatever, an overarching minister with the Minister for Justice and the Minister for Housing, because I think, you know, again, this has highlighted those gaps. And if we only are ever focused on the short term, we never address the bigger changes that we need in the long term for people to.
Yes, a number of those questions. There was another one which I don't have in front of me just at the moment, but it was related to, I think it was a psychotherapist actually, and again, the stress and the stress affecting the immune function and so forth. And I think, of course, the other element of stress is that we read about this first thing in the morning, we read about it second thing, we hear about it before we go to bed at night, we follow the you know, 5 to 6, I'm checking the web to see what the numbers are like, etc. So I'm sure that from this, there's a huge burden. I'm totally aware of it in terms of our students, as you know, and it's an awful time for students from the age of, you know, 18 through to 24, and that it's a time of their lives where, you know, independence, relationships, all of these things, and they're at home in their rooms. It's okay for somebody like me. I can be at home in my room here. It's fine. But you know, for those students, I really feel so sorry for them, and the increased levels of anxiety, and of course then at the tail of that, those who are tipped over into more severe conditions and severe situations, and I really am quite worried about those. I know the Minister for Higher Education is also quite concerned about that, and there's always that balance between you know, keeping the students at home and keeping them safe versus, bringing them in, having some level of, properly organized mixing so that they can both see their teachers and their colleagues in the classes. I know that's something we've been struggling with in the medical school over the whole pandemic, that balance, getting that balance right.
On Clíona's comment on the social determinants, Michael, I mean, obviously to agree, I mean, supporting Clíona's lead both clinically and academically in inclusion health in its broader term, following obviously Aidan Halligan's work in the UK. But I think beyond the marginalized populations, there's a need for social determinants of health to be informed to the general population. What we're doing with regards to exercise, what we're doing with regards to our alcohol consumption, what we do with regards to our relationships as we age, what we do with regards to vitamin D. Obviously a lot of leaders in the Trinity field looking at the role of vitamin D, and our preparedness to be able to address acquisition of infection if we were unfortunate enough to acquire it. A lot of data coming out about metabolic syndrome and its negative impact on outcome. Obesity in a decade younger for people coming into the wards now and transferring to ICU. So whilst the social determinants are within some populations, there's a broader societal determinant to health outcome that this pandemic is beginning to expose, particularly in this wave. And that's around how do we educate ourselves to maybe readjust the way in which, and that they're difficult things to do. I think we need more behavioral psychologists to help us to understand human behavior and to communicate what it is we need to do.
I know there is one on your on the NEFIT group who can advise on that. There's also a comment, I think, rather than a question, about mindfulness-based interventions reducing stress levels and therefore inflammation, etc., which I think is very relevant and reasonable.
I have to tell you a really cute anecdote from the ward.
Please.
So from November, there was one particular ward, 4-bedded ward with 2 men in it, and one of them was really into mindfulness, and he was doing his meditations, and the other guy was homeless, had multiple drug addictions, in and out of prison. So the two of them did a meditation every morning, and the guy who hadn't been used to doing meditations was delighted, and he said he was going to continue it on afterwards, and they both recovered. So it was a lovely meditation moment.
Yeah, I'm sure there is research and trials and other things underway to really look at that and inform our practice going forward. So that's very important. There's been a couple of questions, and just maybe reference one of them in relation to the vaccine rollout. And I know we're sort of a little bit slower than we would like to have been, but it's happening, and that's really good. And there is a clear sort of level of the healthcare workers, very vulnerable people, etc. But just a question in relation to another group who've been working on the front line, so to speak, throughout, and that is people working in shops and supermarkets. And they're there every day, seeing multiple people. And I know there's always individual groups who perhaps deserve to be higher up. Do you think the way it's been done is good? It's well thought out?
So I think the one thing that hasn't been considered or one of the things that hasn't really been considered internationally in vaccination, it has been considered in Ireland to some degree, is around the effect of poverty on people. So, we know that people living in poverty are probably 5 to 10 years older biologically than their counterparts, and that's not adjusted for in vaccine rollouts.
So I would agree with that, but I would probably extend it and say that we have no disease registries. We are confusing chronology with biology, and that we're assuming that everybody chronologically at a certain age is in the very same place. That is a challenge, Michael. However, probably not to use the word prioritization, but sequencing. I think it's not to be politically correct, but to try and inform why things are happening in sequence. There is, I suppose, a network framework to it, underpinned by the Department of Health. There is a data information to it in the sense of more than 62% of deaths in the first wave occurred in residential care facilities. So there has to be, I suppose, back to my point of an analysis of the consequence of mortality and morbidity, hospitalization in ICUs that inform the sequencing. And given that the vaccine in its first place is not about, it's not sterilizing, it is a disease progression prevention approach. So you have to ensure then that you are providing vaccine to those that are most at risk of disease progression. And that has to be informed by wave 1, wave 2, and wave 3, what are different in the cohort today than were different in the cohort last March. I think my second point is the multi-morbid, as Clíona has made reference to. We don't have disease registries. So how do you identify the 60-year-old that has 4 diagnoses over the 70-year-old that has none? And so that is going to be a challenge. And all of this underpinned obviously by a need to communicate what vaccine is doing. You know, I think it's not to take away the hope. The hope is there that vaccination will definitely improve things as we progress, but that it is not necessarily going to be the immediate solution that everybody thinks it is going to be. And that is staggered once we have access to product and once it's safe and once we're monitoring vaccine efficacies by way of national surveillance, we will ensure that everybody is vaccinated. And the drive to this is to reduce healthcare utilization so we can provide healthcare for other non-COVID related illnesses.
Yes, quite a few. I mean, just to say for people on the webinar, there's a lot of questions coming through. We'll try and maybe answer some of them at a later stage on this, but I've been trying to bring a few of the things together to answer them in one group. And one of the patterns that's been asked about is where we see things going over this year in Ireland. What, you know, as things, where are we going to be in September? Where are we going to be in December? Do you think? I know what you're going to say to me, Colm, because you're a scientist. You're not going to overly speculate. But if I was to ask you what you think might be a reasonable scenario.
I would hope by year end we have vaccinated the population, that we have secured vaccine for individuals by age band and by biology and by need. I'm not sure we will have reduced fully our infection prevention and control practices, our social distancing, our intermingling. I don't see that changing, to be frank, before the year end. I think we will have tight travel restrictions for at least till the year end. I think we need to explore the impact that those additional measures have on disease biology, as Clíona referenced. And I think ultimately we're on a trajectory to where this virus will settle. It'll settle within the human, and it'll take probably 2 to 3 years for that to happen. So I don't see a political wish, as Clíona mentioned earlier, for there to be a consequence from the wrong decision. It was clear that the events of December were signaled in the context of both Canadian and American Thanksgiving, which are single day events, although they are intergenerational. Irish Christmas is not like American Thanksgiving for those of us who have lived in North America, or Canadian Thanksgiving, and yet we could see the consequence of the events past. I think there will be a very slow relaxation. It will be informed. So by year end, vaccination of everybody and a very slow relaxation of IPC, or infection prevention and control practices, and hopefully an understanding of the impact of travel and quarantine and social isolation post-travel that informs. And finally, that we actually have the sequencing data that allows us to track virus and the testing data that allows us to identify vaccine efficacy.
I'm conscious of the time, and unfortunately there are far too many questions there that we're going to be able to answer now. We could probably go on for all afternoon at the rate the questions are coming in, but I think people have been incredibly pleased with hearing from you both. I'm really thankful that you've taken this time and for your ongoing work in both the healthcare setting and of course for the medical students, and I know both of you are heavily involved in that as well, so we really appreciate that. So Colm and Clíona, from me, thank you so much for taking this time, and I'll hand you back to Amy at this point to wrap up.
Guys, that was absolutely fascinating. I'll just share my screen quickly here again. Thank you all so much. We're incredibly grateful. You're incredibly busy for giving us your time today, given everything that's going on. I'd like to thank the team here at Trinity Development and Alumni who've helped put the webinar together, especially Alexandra Owens, our technical host for today. And I'd like to thank the audience for all those great questions and comments. If you'd like some more information about today's topic, you can visit the stjames's.ie website /research and the Trinity Medical School research as well to find out more about all the brilliant research that's going on in this area. I'd finally just like to say that our next webinar of the series will be in 2 weeks' time on the 10th of February, titled European Cities Beyond COVID-19, and that will be hosted by the Trinity Business alumni, with guest speakers Alan Duffy, CEO of HSBC Ireland and former president of the Trinity Business alumni, Dr. Martin Sokol, Associate Professor in the Department of Geography at Trinity, and Professor Greg Clark, Global Head, Future Cities and New Industries, HSBC. So we'll be sending out the link for that one next week, so do keep an eye on your inbox. And I'd just like to say thanks again for joining us, and do take care.